Awesome. Thank you. So, welcome to our webinar tonight on the Medicare Maximum Fair Pricing Program. One of the reasons that we decided to put this webinar on is we have fielded hundreds of calls from pharmacies talking about this program and asking questions about it. Um, Unfortunately, we don't know a lot about this program. We do know some. So what we decided to do was go find our partners and people who we know are really studying this problem of this program in depth. And so what you're seeing tonight is a collaboration between six different groups of people. We've got Retail My Meds, AlignRx, Secure 340B, the Pharmacy Insurance Group, Invictus Group Benefits, and the Waypoint Company, all collaborating to bring y'all information on not just how this program works, but how to adequately prepare your pharmacy for this. So what I can tell you is that these people are tremendous partners of ours. We trust them explicitly with everybody here, the information that they're going to give you. I also want to let you know that this is a 30,000 foot kind of view of this program. We are learning things pretty much on a daily basis. I was talking to Julie with Secure 340B, and she's dove into this, and we're learning stuff constantly with this. So this may lead to another webinar as we get more information. This may lead into each one of these entities, these partners hosting their own webinars to dive deeper into what they do and how it's going to impact your pharmacy as it pertains to this program. So we look forward to continuing to bring you more information as we find out. But with that being said, Matt, let's go over some ground rules with this. First things first, we're going to hold all. We're going to mute people joining. Thank you, Nikki. Yeah, we're going to mute people joining, Matt. But we're going to hold all questions to the very end if we can. Everybody's going to get about 15 minutes in this, and then we're going to do a Q&A at the end with this. We're going to try to answer every question that we can. We've created a website with resources where you can also go get updates and ask questions. We're working on creating a couple more communities where you guys can communicate together as we continue to learn more as well. We're thinking about a group me group, things like that. So look for more information coming out about that moving forward. Matt, any of the ground rules you want to cover before we get started?
Okay, I'm not on mute. I was gonna say, let me get off mute. The one thing I would say is there's so many people on this call, and the person speaking is going to be alternating around. So make sure you don't have any video push pinned at the top because that'll block it. And if you want to put it in what's probably the best mode to watch it, if you go up to the top and click on view and change it to speaker mode, then that will whoever starts talking will show up in their picture. So that's my suggestion.
Matt, are we
Absolutely.
able to stop the dinging? Several people are asking.
Oh, okay. So I guess some other people are hearing the dinging.
Yeah, I think everybody's hearing it.
Okay, I can try.
Okay.
Yeah, we'll try. We'll try. So, all right. With that being said, Matt, go ahead and stop sharing, and we're going to let LineRx. We're going to let. I think we have. I think it's Amanda.
Yes, sir. Okay.
All right.
All right. Well, thank you, Matt and Ben, for having me. We are excited to be here. Let me share my screen.
I'm gonna work on the stop dinging, but I can't promise it'll happen real fast. So
That's all right. Thanks, Matt. We appreciate the effort. All right. So my name is Amanda Harvey, and I am the Senior Manager of Pharmacy Services at AlignRx. I'm sure that many of you are familiar with Align. If you're not, we are an independently owned PSAO that serves around 5,000 pharmacies, making us one of the largest independently owned PSAOs in the nation. I've been asked to give a high-level overview of what the maximum fair price, or MFP, is. All right, so we're going to set the stage. The Inflation Reduction Act was passed in 2022, and this is what gave Medicare new tools to lower drug costs to Medicare eligible patients. One key part is the Medicare Drug Price Negotiation Program, or MDP&P. This is what lets Medicare negotiate for certain high dollar name brand drugs. Now, the negotiated amount is called the maximum fair price, or MFP. That's the set price that Medicare will pay for these drugs. To help manage all of this, CMS created the Medicare Transaction Facilitator, or MTF. This system was intended to track claims data and help manufacturers and pharmacies handle rebate payments tied to those negotiated prices. Starting January 1st, 2026, the new negotiated drug prices, or MFP, will officially take effect for the first 10 drugs under the Medicare Part D, impacting pharmacies nationwide to include rural locations. This will not impact the way that your pharmacy buys these drugs. You'll continue to buy like normal from your wholesalers, purchasing at the regular prices. But the way you're reimbursed is what will change. Instead of being paid based on the usual contract rate, PBMs will now reimburse pharmacies at that MFP. Then, to make up the difference, drug manufacturers will pay a rebate to the pharmacy. CMS has suggested using what's called the Standard Default Refund Amount, or SDRA. Lots of acronyms to remember. But basically, this is the difference between the drug's wholesale price, or WAC, and the negotiated MFP. It is important to note that the manufacturers do have flexibility in deciding the actual rebate amount. I know many have questioned how this will display at the time of adjudication, right? So how is it going to show on your screen when you're processing that medication? And unfortunately, this is going to be specific to each software vendor, and we just don't have insight into that right now. I would definitely suggest reaching out to your individual software vendor to see if they have resources or examples of how they plan on displaying this. The rollout of negotiated drug prices will happen in phases over the next few years. So 2026 is the first phase where the first 10 drugs will take effect. These include common high-cost medications like Eliquis, Enbrel, Xarelto, and others. Then in 2027, another 15 drugs will be added, including Ozempic, Otezla, Linzess, and more. By 2028, another group of 15 is set to be implemented. This time it's going to be based on the combined Medicare Part D and Part B spending. Finally, in 2029, the last group of 20 drugs will take effect, bringing the total to 60 negotiated drugs by the end of the decade. Now, manufacturers are required to make these drugs available at the MFP. That MFP negotiated price for a 30-day supply on those 10 drugs are listed here in this image. They can do that one of two ways, either upfront through discounted purchasing or after the fact through refunds. For 2026, all of the discounting will happen retrospectively through that MTF refund process. As the program evolves, we may see upfront discounting through purchasing, so that is something to keep in mind as those next phases roll out for 2027, 2028, and 2029. Because those refunds could take 30 to 60 days to arrive, AlignerX has created a proactive tool to help our members plan ahead. So our MFP cash reserve estimator is available on our AlignerX member portal, and basically this tool helps pharmacies estimate how much cash to set aside for those delays that are going to happen in January. This is going to help cover operating costs and wholesale bills, so we strongly suggest any AlignerX members to log in and review that tool, and if you have any questions, make sure you call our front line. For those of you that are not AlignerX members, I recommend reaching out to your PSAO to see if they have a similar tool or projections that they're able to provide to you and your pharmacy, specific on your data, to help you prepare for what to set aside. Here's how the payment process is going to work. So pharmacies process the claim as usual, but you will only get reimbursed for a portion of that claim. That's the PBM portion, which will be paid out 14 days of adjudication. This typically includes the MFP amount and a dispensing fee. The claim then goes through to the CMS system for verification, then to the new MTF data module. The MTF checks the claim, sends info to the manufacturer, and the manufacturer then has 14 days from them receiving that claim to upload payment. The MTF then issues a remittance notice to the pharmacy, and the manufacturer pays through either the CMS payment module or their own vendor. Due to the newness and complexity of this process, it has been said that it will take 30 days for pharmacies to receive that rebate portion of payment. However, AlignerX believes it could take anywhere from 45 to 60 days before the majority of those rebate dollars start flowing into pharmacies. This is where planning ahead is going to be key in understanding those numbers of what you need to set aside. I do want to point out that on the far right, the manufacturer bypass, that is not going to be implemented until the coming year. So 2027, 2028, we might see that as an option. But for 2026, they will not implement the manufacturer bypass. Now, to get started with the MTF, pharmacies are going to need to go to the CMS MTF enrollment website listed here on the slide. Once you've signed in, the MTF data module user agreement has to be signed by somebody authorized to represent your pharmacy, signing on your behalf. Then you'll complete the standard enrollment form, which will ask key information, things like other MTF users, other employees in the pharmacy that you want to have access to that portal, your pharmacy's demographics, and any relationships with third-party support entities, such as your PSAO. Finally, you'll choose how you want to receive those MFP refund payments. Now, if you've already enrolled, it is very important to ensure that you've enrolled correctly, that you've chosen the correct PSAO and how you want those refunds to be sent. So at Align, if you're an AlignerX customer, we do have a dedicated team that is going through your enrollment and reaching out to you with any errors that need to be corrected and guiding you on that. Now, there is no set deadline to enroll in the MTF. However, some sources do state that pharmacies should be enrolled by November 14th. Delaying enrollment could cause payment delays for that rebate portion, and you don't want to delay it any further. So pharmacies are encouraged to enroll as soon as you feel ready to make sure everything is in place before the MFP pricing takes effect January 1st. CMS has also made it clear that some Part D sponsors may require pharmacies to be enrolled in the MTF data modules, and pharmacies will also need to certify that the enrollment information is accurate and complete in the system. So a question that I have received a lot is, do I have to sign up? Do I have to enroll? And the answer is, if you plan on dispensing name brand drugs to Medicare patients, you will need to sign up. If you do not sign up, you will only receive that PBM portion of payment. You will not receive that manufacturer rebate. Now, there is some additional tools to help provide insight into the manufacturer rebates, and that is the Beacon app. I'm sure many of you have heard the Beacon app tossed around, and maybe you're wondering, what is it? So the Beacon serves as the central communication hub between pharmacies and that manufacturer piece. So they do not actually process MFP refund payments. There's no need to provide your bank account information to use it. Now, while signing up is not mandatory, it's encouraged because this is going to give you that real-time visibility into that manufacturer rebate portion. This can help you track your MFP payments more closely. This is going to give you that first look into, okay, what's the rebate you're going to be paid for that drug that you dispensed. Beacon's website also has a lot of great resources to help pharmacies understand the piece that they play, as well as more in depth of what the MFP is and how it can impact your pharmacy. So if you have not checked out that website, we definitely recommend going and just taking a look at it. So again, that was high level, but what's next, right? So before the MTF can officially go live, there are a few important steps that CMS is taking to ensure that everything works as intended. First, there are enrollment corrections. So they're going through to ensure that these pharmacies are set up correctly, checking it against NCPDP, just making sure that there's no errors on that actual enrollment process. From there, they're going to go to payment module testing, so often called penny testing. This is going to verify that the MTF can correctly process and record financial transactions before any real payments begin. And finally, there's the 835 remittance testing. This is going to make sure that the system can properly receive, read, and post those 835 files from the payers. So all of these steps are designed to make sure that the MTF runs as smoothly as possible. That was a high level of the MTF, and I'll give it back to you, Ben and Matt.
Amanda, we have just a couple questions. Looks
Sure.
like someone's asking do you know of a way to verify the enrollment has been processed?
So you will need to, so once you enroll, if you are on with a PSAO, it will kind of send a message to them to connect you, right? And so if at that time your PSAO is reviewing it, they can reach out to you, or if you log back in and just kind of look back through those items, that's really a way to kind of look at it and verify. But the biggest portion is if you have a PSAO, they should kind of be doing that on your behalf.
Okay. And also, are any of the meds planning on having a decrease in WAC?
Not to my knowledge. Now that is, it's CMS, it's always subject to change, but at this time, not to my knowledge.
And then lastly, people are asking in general, are these going to be slides available?
I will have to get that confirmed, but we can definitely let Ben and Matt know. As they mentioned, we were kind of thinking that this might evolve into some spin-off webinars, so maybe more of us to come.
And then one last question. Will the payment from manufacturers always be 30 to 60 days delayed, or is that just expected at the beginning of the year?
Great question. So that is just expected for the first of the year. The goal is for that to kind of trickle off and you start to see those payments on a regular cadence. So the hope is that I think I've seen it CMS say that they hope to get it to 14 days.
Great. And when should we see penny tests start?
Another great question. And unfortunately, that's just not information that CMS has released at this time.
Hey guys, that's Joe. Hey, let's get let's hold these questions to the end so we can
Sounds
get on
good.
with the next portion of the program. So I know there's going to be tons of questions. Amanda, we're probably going to do a follow-up on this. Obviously, we're going to do probably quite a few follow-ups on this. You know, for those of you who remember when PPP and EIDL came out with COVID, you know, I think we did 3 or 4 webinars just on PPP and then 3 or 4 on EIDL as we kept finding out more and more information to get it out. So just pay attention to your inbox. You know, we'll be sending out updates and we're also on the website we created MFP resources. I'll introduce that at the end. We're also going to be doing updates on that as well. So I'm going to have Amanda, as she gets updates on stuff, she's going to send them to me. I will put them on that website so you guys can go see the information as we learn. We're also going to create like I said, a community where we can share information out to you guys quickly as well as we learn this. So with that being said, Amanda, did you get through all your presentation?
I did.
Awesome.
Sure.
Let's turn this over to Julie with Secure 340B, because believe it or not, MFP is going to affect 340B too. So lots of fun changes. So go ahead, Julie.
Hi, everyone. Thank you for joining. Since Amanda just went over all the MFP information, I'm going to touch on it a little bit as it affects 340B rebates. So as luck would have it, we're going to have not only an MFP rebate begin, we're going to have a 340B rebate begin in January. So my name's Julie Crozier. I'm with Secure 340B. My business partner, Amanda Gaddy, is also on here. We have historically helped independent pharmacies for several years, over 400 pharmacies we work with, and helping them with their 340B program. just because of all the confusion and the unknowns coming on January 1st, we've also added services to help pharmacies work with their covered entities in order to allow these top 10 drugs to remain 340B eligible. Because, and we'll go through why this is, if the covered entities and your pharmacies don't work together, then more than likely these top 10 drugs will not be eligible for 340B. So let's get started. So we already talked about which drugs are MFP drugs. And so a lot of times I'll say top 10, I'll talk about the top 10. And it's true, there are 10 drugs. But for the MFP rebate, just last week we found that Entresto will not be a 340B rebate drug effective 1/1. It will be, I'm sure later, Novartis is getting their plan in. But right now, even though I say top 10 for the 340B rebate, I'm really talking about these top 9. So the drugs less Entresto. So as a high level overview, and again, if you're not in 340B, you can take a little nap. But if you are in 340B, this is the really important information. So today, as you know, all drugs have 340B pricing. So if you look in your 340B account or the CE's 340B wholesaler account, you'll see that there's 340B pricing, assuming that ESP data has been submitted, et cetera, and things like that. But it is 340B pricing is in there. But beginning January 1st, top 10 drugs for all payers, not just Medicare, all payers, will be subject to a 340B rebate. And what that means is if you looked in the 340B account on January 1st for those top 10, or we'll say 9 drugs, any of those NDCs, there's not going to be a 340B price in there. There's going to be a WAC price. And that is what's going to have to be paid up front so that then later a rebate can be made to the covered entity. Now, to make things even more confusing, on 1/1, as we know, the MFP rebate begins. And so on 1/1, the top 10 drugs, or in our case 9, are subject to both the 340B rebate and the MFP rebate. And if you know anything about pharma and duplicate discounts, they're not going to allow that. So there can only be either the 340B rebate or the MFP rebate. And we've got to deduplicate those claims. And this is how Beacon, which is the manufacturer's vendor, has decided to do that. But before we do that, I want to go through a couple more things of 340B today versus January 1st. As I said, the 340B price is in the catalog right now. Covered entities can purchase their medicines directly on 340B. Winner's logic can work because the winner's logic is when the difference between the total amount paid less the drug cost and dispensing fee, as long as that's positive, then that drug qualifies. That works appropriately now. And there's no MFP rebate, as we know. But in January, as I already said, the 340B price is going to be removed for these top 10 drugs. And the CE cannot purchase directly on the 340B claim. And like I said earlier, there's going to be a risk of overlap between MFP and 340B, and the winners only logic is not going to function anymore. To highlight once again what's going on today versus what will happen in the future in January. Right now, you guys, you fill your prescriptions. If you use a TPA, it goes to the third-party administrator. The filters passes that it's that it's a covered drug, that ESP data has been submitted, that it's not Medicaid, etc. And if that passed those filters, then the claim qualifies, the accumulation's added, and either you or the covered entity orders that drug, and the drug is sent to the pharmacy, and the covered entity pays the 340B cost. This is the important part. Right now, for all drugs, they pay the 340B cost. But in January, as I said, there's going to be a difference in process. The pharmacy is still going to fill the prescriptions. It's going to have to pass through the third-party administrator or whoever is reconciling these claims. Then it's going to go to Beacon. Either your third-party administrator will submit the claims, or you or the covered entity or a consultant submits the claims to the pharma platform. And in this case, for next year, it's Beacon. Beacon's going to ask whether the question is whether it's Med D or not. If it's Med D, whether it's yes or no, if it's Med D, the MFP rebate will be denied to the pharmacy. If it's Med D, they will remit WAC minus 340B to the CE. So let me say it another way. If a claim qualifies for 340B and MFP, 340B rebate will always be sent. 340B always wins. Now, when I say the MFP rebate will be denied to the pharmacy, what that means is if it's already sent to the pharmacy, then on the next fill for that NDC where a rebate is due to the pharmacy, that amount will be deducted from that next payment. If the MFP rebate has not been sent to the pharmacy yet, then they will just block it and not send it. But either way, your covered entity is going to get a rebate, which is going to be WAC minus 340B. Now, because of this, there has to be reconciliation between you and the covered entity. You can no longer just have the TPA do what they're doing now, because we're dealing with MFP payments and now 340B rebate payments, and that all needs to be tied out at the end. Otherwise, what's going to happen is these top 10 drugs will be carved out of 340B, and nobody wants that. We need the margins on those drugs, and so we're going to have to get very creative in how we make this work going forward. As I said, the rebate gets sent back to the covered entity, but the covered entity, again, will have to buy the drug on WAC and wait for this rebate to come back. So the last thing I was going to mention is I put an asterisk here. It doesn't affect you guys, but if you're talking to your covered entities, if your CE administers any drugs of these top 10, their clinics or any of the top 10 drugs, if they are administered, that's also subject to the rebate. No area of the hospital or the clinic or the pharmacy can be administered/dispensed on the 340B account. You will always have to pay WAC up front. So just so your eyes cross completely, I want to make sure that your brain is completely dead. I made this obnoxious slide, but I really wanted to point out just a few more aspects of what's going to happen and how it possibly can get rectified. I mean, it can get rectified, but it's going to take, again, collaboration. So for the 340B rebate, we already talked about that it's the top 9 drugs. The MFP rebate is all 10. And the 340B and MFP rebate, if the claim is eligible for both, it's only going to be these 9 drugs, because there is no 340B rebate for Entresto in January. The 340B rebate, all payers are included for those top 10 drugs. Doesn't matter if it's Medicare. MFP, fortunately, that's just Medicare. And for 340B and MFP, when the claim qualifies for both, Medicare is the payer that we care about, because that is the overlap with the MFP. Just to beat a dead horse again, the covered entities have to pay WAC up front. The pharmacies, you'll be purchasing your inventory just as normal on the MFP rebate. And as I said, CEs will have to pay WAC for those drugs. There's a lot of data. This is just part of it that will have to be submitted to Beacon by the covered entity or the vendor in order to get that rebate back. For the MFP rebate, you don't have to submit data. Obviously, you have to adjudicate the claim and wait for that MFP rebate. And as I said, Beacon's going to cross-reference 340B submissions against MFP submissions to prevent duplicate discounts. Lastly, just to let you know how the rebate flows, after purchasing medications at WAC, the CEs will submit claims and the manufacturer issues payments. For MFP, the pharmacy is adjudicate the claim. You guys know this. You'll receive the MFP payment and wait for the rebate. If it qualifies for both, then the 340B rebate will be applied and the MFP rebate will be denied. These are the rebate calculations. 340B rebate is WAC minus 340B. MFP rebate is WAC minus MFP. And the 340B and manufacturer MFP rebate will be WAC minus 340B because, again, only the 340B rebate will be accepted. Who gets the rebate? Well, the 340B rebate goes to your covered entity. The MFP rebate goes to you. And so, and if there's two rebates, the pharmacy doesn't receive their rebate, only the CE. We talked a little bit about timing earlier with the MFP rebate. The 340B rebate is supposed to occur within 10 days of validation. Your guess is as good as mine as what validation means. But 14 days, as we talked about the MFP, but we know that it's going to be longer, as Amanda said. And because it's only going to be the 340B rebate, if there's an overlap with MFP, then it's within 10 days of validation. Finally, what are the risks? Well, for the 340B rebate, the CE is going to carry the cash flow burden because they have to pay WAC up front. They're going to have to make sure that rebate is received. You guys, we already talked about MFP. You're going to carry cash flow burden because the MFP is paid up front and there's going to be a delay for your rebate. And so you need to make sure your rebate is received. And if there's two rebates, as there's MFP and 340B, there's reduced revenue available to split between the covered entity and your pharmacy. So as a result, contracts will need to be more than likely rewritten. There's going to need to be external reconciliation. I don't think that your TPA can reconcile the MFP and the 340B rebate. So an external process is going to need to be added if you want to keep those drugs in. So a lot of stuff going on. It is surmountable, but there will be a lot of coordination that needs to happen. Finally, what you really want to know are what are the next steps if you're in 340B. Number one, communicate with your covered entity because strategic alignment between you and your CE is required if you want to keep access, 340B access to the top 10 drugs. Just like you need to be registered with the MTF, your CE needs to be registered with Beacon. And as Amanda said earlier, we also recommend that you register with Beacon. If you or your CE or your TPA has been submitting claims to ESP to lift restrictions, manufacturer restrictions, that has to continue. You don't need to stop that because if you stop sending ESP transactions, then that manufacturer will block 340B pricing for you. Either you or your consultant, potentially your TPA, depending on if they have the capability, really need to evaluate 90 days of claims to assess the impact of either carving out the top 10 drugs for Medicare patients or carving out the top 10 drugs for all patients. Now, hopefully we don't have to do that again because you want to make sure that you're reconciling everything and working with somebody who can help you keep those drugs in. But worst case scenario, if nothing is done, then those drugs will likely need to be carved out of 340B, and you need to know what that impact is going to be. Confirm your TPA's readiness. We have a questionnaire that we sent to TPAs. If you want to contact us, we can give you that for questions for you or your CE to ask the TPAs because some look like they're going to be ready and some look like they're not sure what the 340B rebate is. You want to assign a 340B rebate specialist, either you or your CE or both, to oversee all of the things that have to happen. Either hire a consultant, have a CE, a point person. Something needs to happen in order to, one person who's also trying to run the pharmacy is going to have a really difficult time managing this. And finally, both for you and your CE, you want to educate everybody about what's going on. Finance is going to have to know, compliance, legal. Everyone's going to have to know what the changes in the procedures are going to be. So if you have questions, you can text myself or Amanda Gaddy, who's my business partner. These are our cell numbers. If you just text your name and your pharmacy name, we'll either get back with you tonight or tomorrow morning, depending on how many texts we get. If you have any questions, any concerns, I know this was a lot. I know you're drinking from a fire hose here, and I apologize for that. But hopefully this was helpful in getting a high-level overview of what's going to happen on January 1st.
Thank you. Thank you, Julie. And I just dropped Julie's cell phone and Amanda's cell phone in the chat.
Ben, can we put those in the follow-up email that we send with the link to the video as
100%.
well? And
100%.
anybody in Align, whoever wants to contact, whoever you want to be your primary contact, just make sure Ben's aware of it.
Yep, absolutely. Follow-up email is going to go out with a recording, and we'll have all this on the website. You can get more information on mfpresources.net. We'll talk about that at the end. So, somebody just posted this sounds horrible. Not to be a Debbie Downer, but this sounds horrible. That's why we're having the webinar now to get prepared for it, because it's this, I mean, it's just there's a lot of work has to go into this to be ready for this, and to make sure that we're doing this. Now, as we continue to learn more, I promise you, between Julie and Amanda on the 340B side and Amanda Harvey and the team at Align, they're going to be working their butts off to try to help simplify this and make that transition as simple as possible to this stuff. So I have no doubt. So with that being said, we're going to turn it over to Erica Collins with Retail My Meds, and I'll let her talk to you about her program and how you can boost cash flow and to help you guys, kind of weather the storm that's coming.
Well, good evening, and thanks everyone for joining us on this webinar late in the evening. So I definitely appreciate your time. It is sort of a depressing situation, isn't it? I named my presentation this evening "Thriving Through Uncertainty," and so we have to sort of just have the mindset that we're going to power through this and make it happen. So who I represent is a company called Retail My Meds. I am an independent pharmacy owner with 17 years experience, still own an independent pharmacy. The approach that I take with Retail My Meds is that maybe it doesn't make sense to fill drugs that are not profitable or that have any questionable profitability moving forward, especially during this time of uncertainty. So I'd like to talk to you a little bit about our novel approach and how you can navigate the MFP challenges. So here's what we know. So we know that 2026 is going to bring about a shift in Medicare drug reimbursements. It's a financial turning point for us. CMS begins enforcing MFP drug pricing negotiations on 10 drugs. We know this is just the beginning. With every year, there will be more drugs, more delays, potentially, depending upon how streamlined the process becomes. Pharmacies are facing these delayed payments and reimbursements, and we are being told we need substantial cash reserve to be able to cash flow our businesses during this time. So the traditional fill and bill model is financially risky under these new rules. And then we don't even really know, will the new reimbursement model prove profitable? And if it is profitable, does it make sense to continue to fill prescriptions that are marginally profitable? And so that's where Retail My Meds can provide a strategic response. It's a very proactive approach. So for those of you who haven't heard about Retail My Meds before, it is a software company and a service that I created in my pharmacy that I then chose to share with other pharmacies. And through our proven process, we train your pharmacy team to coordinate prescriptions with mail order pharmacy for fulfillment. It didn't make sense to me in my pharmacy to fill prescriptions that I could not purchase cheaply enough, nor could I affect the reimbursement. So I thought, I'm going to send these prescriptions to someone else, another pharmacy that is profitable on these prescriptions, because they have more flexibility in what they pay and what they get reimbursed on said drugs. But the cool thing is that I'm going to take care of my patient, and I'm still going to be at the center of their care. So these prescriptions, when we outsource them to mail order pharmacy for coordination, can be shipped back to the pharmacy or directly to the patient. depending upon state pharmacy statutes and really the pharmacy or patient preference. And when we started developing this program within our pharmacy, the original idea was, I don't want to lose profit. I don't want to lose money every time I fill a prescription. But what became very apparent early on is that this is an amazing way to improve or boost cash flow because you're not reordering medications that are non-profitable or marginally profitable and tying up your cash. So as we developed the program and began to see it work, we understood that there were a lot of additional benefits, which we have listed here, everything from reducing audit risk to maintaining patient access. But thinking through this presentation, I thought, well, we're adding a new one to the list. We're going to eliminate reimbursement uncertainty. So this is a new benefit I'm excited about. So let's think about what's going to happen in first quarter 2026. We can now prepare to reserve cash, or we can pivot to improve cash flow now. So pharmacies, you do have a choice. According to CMS, you will have to enroll into the Medicare transaction facilitator to maintain contractual obligations to fill other meds, and when we know that this is a requirement, but it does not place any requirement on pharmacies to actually dispense the drugs under the Part D program. So what I did is, looking at the traditional pharmacy fill and bill model, many pharmacies, as we all know, are cash flow strapped. We're barely making ends meet, and then this is just one more thing that we have to deal with. So cash reserves needed, could be up to 90 days, and that will be difficult for a lot of pharmacies to manage. What I did is I just created a super simple estimator chart. So just looking at the number of monthly MFP prescriptions that are filled in the pharmacy, most common ones, Eliquis, Januvia, Entresto, Jardiance, looking at the monthly reserve needed if you filled 10 to 60 of these prescriptions. Now, I know that a lot of pharmacies actually could probably multiply those numbers by 10 very easily. And so you can kind of see a little bit about how these drugs would impact cash flow. So looking at a blended average of what we think the estimated cash reserve will be needed for these scripts, you can easily see how with several hundred prescriptions, your estimated cash flow or cash reserve would be exceeding $100,000. Okay. Now, a lot of pharmacies, again, they don't have that. So then the question becomes, what are we going to do? Are we going to take the traditional path of stocking and dispensing the drugs locally, using our cash reserves, tying those cash reserves up in uncertain reimbursement, exposing ourselves to these delays, risking negative cash flow per fill after the rebate is applied, and then adding additional stress on our operations and patient access, okay? Or we can consider the Retail My Meds path. And so the approach that we want pharmacies to take is to identify your MFP exposure early, shift those high-cost fills to alternative pharmacies for fulfillment, reduce or eliminate the need for the reserve capital, and start 2026 with improved financial stability instead of figuring out where that cash reserve will come from. Maintain patient access via coordinated prescription transfer, keep your pharmacy relevant in the patient care team, avoid reimbursement gaps and manufacturer refund delays, free up your resources to focus on profitable, patient-centered dispensing and services. But ultimately, let's provide care without compromise. I'm tired of compromising. I don't know about you. So taking one step just a little bit deeper into the Retail My Meds process, what we want you to do is to run monthly reports to identify prescriptions that are affected by MFP pricing and the associated acquisition costs of those prescriptions monthly. If you do not know how to do this, contact your software vendor. They will help you build this report. Then you want to subtract the CMS MFP values to estimate your cash exposure for each prescription, or alternatively, you can use AlignRx's estimator tool to determine really how much exposure you will have moving into 2026, because knowledge is power. We need to understand what our needs are so that we know how to eliminate them, to eliminate these prescriptions. And I just want to give a shout out to AlignRx for building this estimator tool. because they've taken a very proactive approach in trying to educate pharmacies on on exactly what's happening and what the needs are. So then register with Retail My Meds and complete our program training. You can implement our program in one day. It is that easy. You don't have to wait weeks or months, and you don't have to make it overly complicated. You can train on it in a day. You're going to coordinate these transfers of these drugs weekly out of the pharmacy systematically, and then let the mail order pharmacies fulfill those orders. Then simply maintain those reorders every 90 days, utilizing our software to manage those prescription needs. And the cool thing is if you are ordering these prescriptions for 90-day supplies in November and December, you're going to get past that 60-day window of uncertainty in the first quarter of 2026 when all of these timelines are being worked out and the reimbursements and those types of things. So, that buys you time to decide if you want to bring these prescriptions back. So in the little bubble, we just listed 6 quick steps of what it actually takes to implement Retail My Meds on the patient level. And that's not something we're going to get into tonight, but I wanted to add that just so you guys understand it's a simple process. It's straightforward. And so we can dive into that at another time on another call if you guys have additional questions on that. So let's say we take this proactive timeline and we want to improve our cash flow before January 1. Remember, you can strategically resume dispensing these prescriptions if the reimbursements make sense and if the timelines are financially viable. But at this point, if you bring these prescriptions back into the pharmacy, you control how many you fill, when you fill them, and do this in a way that makes sense for your business. At the end of the day, you've got to protect the financial health of your business first and foremost. Okay, your patients are going to be okay with this prescription coordination process. This is something that we train on with our service as well. So rest assured that you're going to still maintain your patients in your pharmacy by offering this solution for your pharmacy and for your patient. So just quickly, we estimate that the average price, the acquisition cost rather, of a brand name drug is about $550. Now, these are not including specialty. They're not including our beloved GLP-1s. But if you look at the average cost of a brand name drug at $550, and if a pharmacy could commit to transferring out 20 prescriptions weekly between the week of November 9th through January 3rd, they could easily put $100,000 or roughly a 6-figure improvement in cash flow back into their bank account. That's improved cash. This is money in the bank to spend. This is not a cash reserve. This is not a loan. Like, this is your money that you are strategically holding because it doesn't make sense to dispense these drugs at this point. So it is feasible to transfer 20 prescriptions per week. We all have slow times in our pharmacy where we can find an hour or two here or there where we can implement this program. But if you make a concentrated effort to get 20 scripts a week out, I know that $88,000 figure would actually be higher. So just an estimate there. So that's basically what I have for you guys this evening. If you're interested in learning any more about our program, you can text retail to this 833-771-1886 number. And then we will send some information for you so that we can make contact you. Or you can go to the resources page, which I think Ben will be speaking about here just momentarily. So we look forward to hearing from you guys if you have any further questions. We are also going to be hosting a deep dive webinar next Thursday, November 13th at 7. For those of you who may have additional questions or really want to look at the process more intently. So thank you so much for your time. I appreciate it.
Awesome. Thank you. Thank you, Erica. Again, I posted in there. I got Julie and Amanda from Secure 340B. Text them if you want to talk to them about 340B. And or text the word retail to 833-771-1886, and that will, I think, lead you to a special landing page where you can register for the upcoming webinar or get the process started to implement Retail My Meds. So Thank you all. I do want to, before we get to the question section, I do want to bring up one thing. Actually, one of our partners, Invictus Group Benefits. Um, I don't know if Reese or Scott, you want to talk a little bit, but one of the things that we have been doing is saving pharmacies a lot of money on their employee benefits side of things as well. That's another area that we have identified that pharmacies have kind of haphazardly kind of managed. There's been really no strategy to manage, and so I don't know, Reese, if you want to talk, or Scott, you want to tell a little bit about kind of our new program for pharmacies
Reese is
on the health
unmuted,
insurance side, helping them
and
save.
Scott is. Reese and Scott both are unmuted now.
Yeah,
I'm gonna let Reese take over. I'm the Medicare guy, so.
And thank God, because if I have to hear any more of this Part D, MFP, all this other stuff, I mean, it's 7:53 here in mid-Missouri, and my brain is fried watching that. I saw the comment come through about not to be a Debbie Downer. My hands went up. I'm like, oh my God, he gets it. This
Yeah.
is atrocious. So I just my quick little elevator pitch. I work with Scott Amos over at Invictus Group Benefits. We teamed up. I'm a benefits consultant by trade, so I'm familiar with the commercial plans. The TPA language makes sense to me. There's really two ways that we help pharmacies, three actually, if you haven't heard of Invictus on the Medicare side. But personally, we can help you guys partner directly with those employers. I'm all about the cash deals. On a consistent basis every week, I try to throw punches at CVS, Caremark, at Express Scripts, and at Optum. So we're out there, throwing haymakers too. And you guys have a really unique position. They trust you. Nobody likes salespeople like me. You guys as pharmacists have a unique backdoor into these employers' pockets. You can work with them. They can work with you directly. We talk about clinical networks, value-based care contracts, all that stuff. So don't let your large, self-funded, specifically employers who are already likely coming to you saying, hey, we're going out to RFP, right? Request for proposal. We're going to look at 4 different PBMs. They're asking you about that because they trust you. You've been their, pharmacist, you've helped their family, etc. We'd like for you all to be able to monetize that conversation. And it's the best kind of money. It's mailbox money. And it doesn't come in a rebate check. It's cash every month. And then the second way, as Ben mentioned, is we've developed a program that's goal is to reduce what you guys spend on healthcare for yourselves and for your staff. So if you are a small pharmacy and you offer an employee benefits program, that too is on an escalator up and to the right. It's 10 to 15% a year on average. We have created sort of a healthcare providers program. So we've included other doctors, whether they own independent practices. We've got chiropractors, dentist office, ophthalmologists, you name it, any sort of healthcare provider that falls in that asset class or that industry code. And on a relatively consistent basis, we'll call it 80 to 85% of the time, we see commercial health insurance rates anywhere between 15 and I saw one today that was 37% under the commercial market. We don't work with some of the big BUCA companies, like I've already mentioned. That's Blues, United, Cigna, and Aetna. I heard a story earlier where the pharmacist is like, my own employees can't fill their brand prescriptions here because I lose money. I have to send them to my competition. That's the definition of sort of internally cancerous. So there's ways that we can help you guys from your expenditures and what you spend on healthcare. And also we want to hopefully show people who have the conversations with employers. And then Scott has an entire different Medicare ring, but it's late and I'm going to spare you all the time.
All right. Thanks, Reese. Yeah, absolutely, guys. So I think the whole point of this, Matt, go ahead and pull up the slide for questions. I think the whole point of this is that, yes, this is challenging. Yes, this is brutally hard to listen to, especially the 340B stuff. It's really hard what you guys are going to be asked to do. But I think the whole point of this is that you see there's a group of people out there who really care about independent pharmacies, really understand the impact that y'all make and are trying to find ways for y'all to continue to make this profound impact in your communities and the families, for the families who need it. And at the same time, find ways to make money too. So yes, we are in some challenging times. They're going to continue to be challenging. But I can promise you this: we are working our tail off. Partivtry.net, mfpresources.net. Try that one. .com is a trucking service. .net is our resource page. So my point to y'all is just remember we are really working hard. So I want to go back to some of the questions, Joe. Let's go back up to the top here. This was during Amanda's portion after the penny test. Amanda, this is for you, Amanda Harvey. for you. What are the copays going to be? And Joe, I'll let you ask the next one, but what are the copays going to be for patients for the IRA meds? I know insulin is $35.
So that is also not something I have visibility into. I know we talked about continuing the series or posting some questions, so I'll definitely research, but to my knowledge, I have not seen that posted.
I think Scott's got an answer to that.
Yeah. I may be able to help with that just a little bit. So, just kind of seeing, especially on the Medicare side of things, as far as copays wise goes. So, as the IRA came in, it's kind of a double-edged sword. So the cost of the medications actually, like let's take Eliquis for instance. Normally $600. The actual cost on that's going to $250, but most every drug plan and Medicare Advantage plan has a deductible with it. So copays are varying. United Healthcare put co-insurance on their plans instead of an actual copay. Humana, on the other hand, has been very, very hot this year, and their deductibles after tier 4 or after tier 3. And so their copays are running $47 on these MFP drugs. So,
yep. So it just depends on the plan, right? That's really just plan.
And actually, Novolog's actually at a percentage on most plans, and you're looking at actually lower than the $35. So on your C-SNP plans, they're going 25.
Okay. Yep. That's chronic care, special needs, guys. If you guys have questions about this, Scott, will you put your contact information in?
Absolutely.
As well. I know Reese put his in, but put your contact. If you guys have Medicare specific questions about the health plan side of things, Scott's a great resource for that on the Medicare side. So perfect. All right. Gabe asked, I think this is for Amanda Harvey. You want to ask that one, Joe? Are the manufacturers rebates that one?
Yeah, are the manufacturer rebates going up to whack? Amanda?
I believe so. I do believe so. Again, I'd have to get back to you on that.
Okay. all right. Again,
And then yeah.
go ahead, Joe.
I was just saying a follow-up question, not for Amanda. I think this was for 340B. Will this include generic Entresto?
Yeah, we Joe, that one got answered by Amanda.
Gotcha.
Yeah,
Okay.
guys, again, just if you go to mfpresources.net and you subscribe down at the bottom, you'll get updates as we get them, and we'll be posting updates there. But it's also becoming apparent to me that we're going to probably have, there you go. Thank you, Matt.
Hey.
We're probably going to have to, at the same time, do another couple webinars on this. So Matt, scroll down to the bottom.
Hey,
But
Ben.
Go ahead, Scott.
On the Entresto thing too, just for everybody's knowledge, there's not a single carrier that's actually covering the brand Entresto in their formulary.
Yep. All right. That's why I couldn't find it covered the other day, Scott. That's good. That's good to know. So, all right, Matt, scroll down the bottom. Scroll down the bottom here. You'll just come down the bottom here. Keep going down. Is that as far as it goes?
Yep,
All
that's
right.
as far as I can go.
All right. So, okay. I forgot to update the website, but I'll get it updated at the bottom. You'll see subscribe to updates and just put your email in there, and we'll get all updates. The other thing is when I email out tomorrow, I'm going to create we're going to create a group me group as well, and I'll include all of our partners in there, so you guys can actually start to communicate if you have questions about this, or hey, we're seeing this, are you guys seeing this, and get responses back from other pharmacy owners across the country. So we're going to do that. I'm also going to, Amanda, I will send the recording to you as well if you want to put it in the AlignRx portal. I'll send that to you. Feel free to do that as well if you want to.
Hey, Ben.
And for the other partners, go ahead, Joe.
A couple people were asking about Erica's program, if she could put her information in there, if she hasn't already.
Yep. I'll put Erica's direct. I mean, Erica's, retail my meds. If you want to reach out to her personally, Erica, can I share your email? Is that okay? We lose Erica.
No, yes, it's fine.
Okay. All right. If you guys want to reach out directly, you can text that number and go sign up for the webinar. Or click enroll now if you want to start the process to enroll in the program, or just you can email Erica as well. So great, thanks, Joe. All right, Joe, what other questions do we have?
Looks like patients with negative experience with a mail order or flat refuse to make the switch. Um, any mail order pharmacies that have positive customer experiences. Not sure who that's for.
That would be me.
For Erica, yeah, for Erica.
So what I would say is, in my experience, most of the negative experiences that patients have with mail order really comes down to their lack of understanding the process involved with pharmacy in general and the timeline to mail a prescription. What makes pharmacy employees work very well with this program is that we speak that language. And so it's about timing, it's about understanding what's involved. And what we have to do is we have to lean into the relationships that we have with our patients and understand that your patients trust you. And that is the one thing that you have that money can't buy. And if you talk to your patients about the honest necessity at this time and sending some of these prescriptions out and giving them the peace of mind that you will work with them to make sure that everything is delivered appropriately and that you're going to be in charge of that on their behalf. You're not sending the patient off to figure it out themselves. You are coordinating it for them and you are handling it in your pharmacy in-house. So again, I don't think that's an issue. I can understand the misconception, but we will train you or your staff on how to appropriately have that conversation. So that's not an issue.
Okay, we have a question. Any insight into whether 340B rebates for Ryan White programs will be affected?
Yeah, I think Julie answered that, but Julie,
Okay.
you want to kind of just speak to that because there might be other people who maybe missed that in the chat.
Yeah, so I mean, I believe that's what if he's asking. The rebate, 340B rebate is going to be applicable to all covered entity types. They confirmed that last week, so it's not just hospitals or, critical access or anything like that. It's all entity types, including FQHCs. So it will be affected.
Okay.
And
All right,
Ben, on the MFP resources, it's .net, correct? Not .com?
.net, correct. Yes, .net. Yes, yes. And I updated the page today, and I forgot to hit save. So there was also one about does MFP affect LTC? And I think Amanda Harvey responded yes to that.
Yes, that is correct. That will also, as Julie kind of stated, that is going to affect all of the Medicare eligible patients across all walks of life. So LTC included.
Okay. All right.
I think that's it, Ben, that I see.
Okay. All right. So,
oh wait, one more for Erica. Is there a charge to the patient through mail order, or does the pharmacy pay or the patient?
So if you're referring to copays will need to be paid at the mail order level. The local pharmacy can arrange that payment by working with the patient. In terms of our service, there is a monthly subscription fee for participating pharmacies, and there is no additional charge on our end to your patient.
Okay, great. I think that's all the questions, Ben.
hey, Joe, I'm gonna. Oh, I think we just had another one come in. MFPresources.net. Matt, pull up that slide again.
You can't see. Okay, let me go back and say you
Go
can't
back to the
see it
slide.
online.
Yeah. MFP resources. I do have some. I do. Carrie Truman with Alliance sent over some questions that I think need to be covered. A couple of them haven't been covered. All right. So the first one is do I really have to participate in this? The Debbie Downer quote is like, hey, what if I just don't want to participate? I don't think you have an option, but maybe Amanda Harvey, can you answer that? Do we really have to participate in this?
Yeah, so from the point of view, if you plan on dispensing name brand medications to Medicare patients, you will need to sign up for the NCS. Otherwise, you're going to be missing a portion of that payment. You're only going to get that PBM portion, and you're going to want that rebate. I know that Erica kind of teed up some different options there, but from the standpoint, if you plan on dispensing those name brand medications to Medicare patients, yes, you have to sign up.
Yep. All right. And you just answered, if you don't sign up, you're not going to get the MFP rebate.
Correct.
Okay.
And Amanda, just to clarify, like even if you don't dispense MFP drugs, you have to still enroll in the program so that does not affect your contracts moving forward, right? On anything. Like that may impede your ability to be contracted and bill these plans for any prescription.
Yep. Yeah, did that make sense, everybody? Is that, Amanda, do you confirm that?
Oh, yes. Yep.
Okay, it's confirmed. Good. All right, awesome. Lucy asks why. Is that is this go ahead.
So I'll take it, but ladies, please step in if I'm missing the mark. But the understanding is that they have partnered with CMS has partnered with these manufacturers, and that was the piece in one of my slides talking about PBMs are going to make you attest to the fact that you have signed up. So that then becomes part of your contractual agreement. So that is why.
Okay. John says, did I hear someone mention generic Entresto was covered next year in Medicare? If so, are we expecting improved coverage for Farxiga generic as well? I think that might be is that Amanda Harvey again? Is that you a question again, Amanda?
That was not a me. I think maybe Scott. Sorry, Scott, if I'm calling you out, but
Scott might know that if he's still on.
Hey Ben, I'm so sorry. I was answering an agent's question on text.
Okay.
What was the question?
Did I hear someone mention generic Entresto is covered next year on Medicare? So the plans are covering generic Entresto?
Yes. Generic Entresto is so. Yep.
How about Farxiga?
It's still expensive.
Are we going to see improved coverage for that?
For what?
For generic Farxiga.
Yes, you will see that Farxiga is still covered underneath carriers. So you may be, and that's where the $2,100 cap, and I feel like negotiating drugs actually probably hurt some people going forward, or our Medicare recipients going forward, because they're not hitting the cap quite as fast with the MFP drugs because everybody's on Eliquis or Farxiga or Xarelto or whatever. So, but yeah, so I mean, you're gonna see a lower cost on that too. But right now, Farxiga's winning by far in the formularies.
Okay. Can we bill early the 10 meds that are due to be dispensed in early January to late December to help with the 30 to 60 day delay in payments?
So that's going to bounce back to your contracts and what the contract allows. So it's going to depend on those factors. I have to be careful of how I advise and answer that one, but that's it's going to be dependent on the contract.
Yep, absolutely. Can we get reimbursement difference from previous year's billing?
So I would say that that's a great opportunity to either reach out to your PSAO or your software vendor to pull your data to see the difference there.
Yep. RX 1206. Yes, we will send out a replay of this along with all the slides.
Yeah, Ben, that's gonna be sent out tomorrow to everybody, or
it'll be sent out tomorrow, and it'll be posted to if I can remember to hit save, it'll be posted to rfpresources.net.
Gotcha.
Yes. Cardinal. Why does Medicare Part D make everything so difficult?
I'll take that one.
I'm not yet, Scott. I'm not sure we have enough time for this one.
Yeah, well, anything a part of the government's going to be difficult. All right, so
that was going to be my point. Yep.
Yeah, absolutely.
Yep. Wyatt put CPSN members have a dashboard with info and MFP data. Thank you for posting that, Wyatt. All right, couple other questions. Carrie Truman teed this up for you. And I don't know if this is important, but maybe Amanda, you can talk about this. When I'm filling prescriptions at the pharmacy, how will I know that a drug is one of the 10 negotiated MFP drugs?
So checking that list, right? So using resources such as cms.gov or your PSAO to keep you updated on what that list is. So that list of 10, sorry, let me find my slide deck. So that first list of 10, that's not going to change. That is Eliquis, Enbrel, Entresto, Farxiga. I should not speak on some of these.
Enbrel?
Enbrel?
No?
Imbruvica or something?
Yes, thank you.
Imbruvica? Yeah.
Yep. Januvia, Jardiance, Novolog, Darla, and Xarelto. So that's not going to change. But those lists are displayed on cms.gov, and I'm sure your PSAO, I know Align has a lot of resources with those drugs listed as well. And the next 15 and the next 15 and then the 20 ones still get displayed as well. So that will be constantly updated on CMS and other resources.
All right. How do we know if I'm enrolled? How do I know if my pharmacy is enrolled? Is there a website or something I can go check that it will say you're confirmed enrolled?
I would say that you would know if you were enrolled because it's a little bit of a headache of a process. You're not going to accidentally get enrolled. If you have not gone to the website, which is it's mts.cms.gov. If you have not gone there to fill out, it's quite a bit of different pieces that it's going to ask for. If you have not done that, then you're not enrolled. I would also go to that website if you have started enrollment and you want to confirm that it's correct or that you've hit finish. That's where you'll need to go as well. That's
my next question. If you go and you see pending, what does that mean? Does that mean you didn't fill out the application correctly? There's something you didn't do right? If you see pending, what does that mean?
Yeah, so the PSAO has a little bit different view than what the pharmacies do, but if it says pending, there should be a next step for you. Reach out to your PSAO if you need some help. I know Align, we've gotten a lot of questions. We might not know or have seen it, but we'll get in there with you and we'll figure it out together. But if there's something pending, then you definitely need to ask some more questions.
Absolutely. Just for your own, we got another question, but Amanda, just for you to know, somebody posted in there, I have trouble saying the drugs too. So
I saw that. Thanks for the support.
All right. Does this mean PBMs are no longer getting a rebate for these specific MFP meds? Is this why ESI is no longer using a rebate model as they say?
I cannot speak to that.
Okay. All right. Yeah, I can speak probably to that. I don't know if that's truly the case. If that's why they went. Scott, you might know why they didn't go to a rebate model or they went away from the rebate model.
Yeah, my best guess is that they're not going to lose money one way, So I mean, but
it's whack-a-mole. It's kind of whack-a-mole, right?
Whack-a-mole. Yeah.
Yep. All right. Any advice for Medicare plan reviews and for patients in regards to the MFP drugs? Scott, that's another one for you.
Yeah. I mean, so, Medicare.gov is still going to be a good player. I mean, if you can get with a local, like another pharmacy that's doing the Medicare agent program that we provide to make sure that they're going to be staying into your pharmacy is a great way to do that. A lot of the Part D plans are non-commissionable, so you've got a lot of agents out there. I just talked to one today that said that the agent in town is not doing Part D plans anymore. So I think this is a great way of being able to keep people in the pharmacy and control payer mix too. So.
Yep, absolutely, 100%. Yep,
Right,
yep.
Will the pharmacy get in trouble for not filling the brand medication and transferring them out?
No, they will not. It's still the patient's right to choose where they get their medications filled. And if they want to send one prescription or two to mail order, and keep the balance of their profile with you locally, they have absolutely every right to do that. Our relationship is with the patient, not with the PBM.
Yep. Yep. And I want to go back to Angela. Yeah, Angela, one of the, if you on MFP resources page, you'll see under the pharmacy insurance group, one of the things that we have done is help pharmacy owners start their own insurance agencies. They work kind of symbiotically with the pharmacy to help you with this, to help your patients manage this and help you manage this. So it's, you can do this. You can own an insurance agency and have an insurance agent who helps your patients with this. If we've seen so many people send out, yeah, like Scott said, we've seen so many people send their patients out. And if you've got agents out there because Part D plans aren't paying commissions anymore that are, basically, trying to square peg round hole somebody into a Medicare Advantage plan that doesn't work, it end up hurting them and your pharmacy. So that's one of the areas that we highly encourage that you influence your patients, by helping them. They're trying to navigate this. They don't know what they don't know. And so that's another thing. So if you're interested in that, just go to go down to on the website, click I'm ready to start an agency, fill out the information, we'll get with you. And I think it's going to lead you to
hey Ben too, like it'd be hard to get going right now, getting insurance license and everything, but this is always a great time to be able to do this for turning 65 and make sure we keep people in the pharmacy. Turning 65, we can retain those. They're looking for information. They're looking for education on Medicare. The other thing is like right now too, if you need a review, RX Insurance Group has internal agents too that's going to keep people in your pharmacy. So
yeah, absolutely,
they can always help out.
Yeah, that's really important. So if you we have our own internal agents that we've trained that are really that are focused specifically on keeping your patients in your pharmacy. So if you have if you have patients and you're interested in learning about how to send those over to us, we've created a real simple process for you to send patients over to us, and our agents will keep them in your pharmacy. So thanks, Scott. Thanks for pointing that out.
Yeah, the one thing I would add is if you don't have a plan for that, they touched on it. So many of the Part D plans are non-commissionable now, and a lot of insurance agents watch their bottom line just like pharmacy owners watch bottom lines, and a lot of insurance agents aren't showing a bunch of non-commissioned plans. So if you just assume that the agent down the street is going to help people stay in the pharmacy, that may not be the case this year, even if it has been in the past.
Yeah,
Right.
yeah, it was bad. It was bad in the past. It's only going to get worse now. If like I say, if you're not influencing patients like that, I would highly encourage that you look at that program. We've made it super simple to get started. It's very cost effective to get started as well too. So it doesn't cost a ton of money to do it. So, all right. So CVS, yes, go ahead.
I was just gonna say the CVS comment, but below there, Ben, someone's asking if there will be another webinar.
Yeah, we're probably going to do a follow-up webinar. We had over 800 people respond, and we had, I think, 250 come. So we're probably going to host another webinar for people who couldn't make it. All right, Matt, Wishek Drug. This is being recorded. It's still being recorded. Wishek Drug, Matt, will you send over, actually, I'll respond to Wishek. Just email me your email and contact information, and I will get with you, and we'll get you started on helping you refer patients over to us. Yep, that is not. I'm not as shocked that your local insurance agents are not being informative to your patients. Absolutely, I can guarantee you that's not the case. They don't. What we found is on that side of it is a lot of insurance agents, they don't have the same care. They don't have the same level of care that you guys have for your patients. They just don't. And, so there are a lot who do. Don't get me wrong. I'm not painting everyone in a bad way. There are some good agents out there. Scott and his team are really good agents, and that's why we partner with them. But yeah, so you're taking that level of care for your patients, and then you're, if you decide to start your own insurance agency, you're going to apply that same level of care for them, helping them pick their insurance plans. Or if you send them to us, our people will do it, or we'll fire them and find other agents who will. So, all right. Yeah, so this is being recorded, Stanley. It will be uploaded tomorrow to mfpresources.com. It will be also sent out in an email. So we're at 8:21 here. So I know it's 9:21 on the East Coast. So I'm gonna let's let everybody go for tonight. Keep an eye on your email tomorrow for this. There will be
Yeah,
updates post. Go ahead.
it's gonna take a while to download. So the recording will not go out tonight. I'm gonna leave my
No.
computer plugged in and downloading, so it'll probably go out tomorrow morning.
Yep. Yeah, and thank you all. Thank you to our partners on this. We truly are grateful. For those of you who don't know, this was put together in essentially less than a week. So our team really came through with this, and these people really care about you. If you're not doing business with any of these partners, I'm telling you, pick your partners wisely. Pick them wisely. Do business with the people who care about you and who have your best interests at heart. And so thank you all for coming, and have a great evening.
Thanks, Ben. Thanks,
you,
Matt.
Thank you all.
Thanks
guys.
everyone for participating.
Matt, don't end the meeting yet. I want to
Okay.
grab the chat.
It should capture it in the recording, but yeah, if you want to.
I just hit save chat. Thank
got
you
it.
all.
You were able to save it, Ben?
I hit, yeah, let me do it one more time. Save chat. Let me make sure it pops up here.
I usually just copy and paste the whole thing just to be
Yeah,
sure.
if you want to copy and paste it, Joe, that'd be great.
Okay, I'll do
And just
that.
send it out to us. Again,
That was good. Amanda, Julie, Erica, good job. If they're still on, they're
thank
probably
you
gone.
all. Yeah. It's 9:21 East Coast time. They're pooping,
And
sure.
it's like this is the worst week of the year for me in terms of being tired. I can go to bed at like 7 o'clock.
Yep, Joe, I've got the chat. Yeah,
Okay.
Joe, I've got the chat saved. So, all right, Matt, appreciate it. Thanks for
Thanks, guys.
driving.
All right.
Thanks
Yep.
for
Thanks
driving the train
everyone.
tonight. Thanks, guys. Bye.